around the world to contribute for innovation in their own country. So we'll hold questions till the end. And next is a friend from Singapore, an overview of 2013 lower extremity angioplasty from Singapore General Hospital. My friend Tech Chong, professor and head and senior consultant, Department of Vascular Surgery at Singapore General Hospital. Take it away.
Thank you, Dr. Vidyanathan, for the great opportunity to be here. I'm glad to be here with my former colleagues, boss, Dr. Sachs, Dr. Fontaine, Dr. Vidyanathan. I just arrived from Singapore this morning, so I may not be as animated. I'm going to talk, I'm a vascular surgeon, that's my only disclosure slide, from Singapore. We're a public hospital in Singapore with about 1,800 beds. I'm in Philadelphia, so I can't talk about history, but we were built by the British about 203 years ago now. Considering the country was only formed in 1965, it's an old hospital. It's a public hospital with tertiary care services. We provide elective surgery for about 50% of the population of Singapore. I put multidisciplinary care here because I formed a vascular institute in 2019 and brought together interventional radiologists, cardiac surgeons, vascular surgeons, interventional nephrologists, all around the treatment for vascular diseases. You can imagine how difficult that is, knowing the egos of all these doctors. We perform about 700 to 800 lower limb angioplasties a year for mostly critical limb ischemia patients, and they're done by the vascular surgeons as well as interventional radiologists. So I'm going to focus the talk on the Vascular Quality Initiative. Those of you in the US know this is launched by the Society for Vascular Surgery. More than 1,000 centers across 14 registries, and Singapore General Hospital is the only non-North American site when we started in 2019. And the title is a bit outdated. I figured we're going to update it, so it's 3,135 cases instead of 2,020, whatever it is. And we're going to compare ourselves against 220,000 procedures done in the US by 406 centers. The time frame is seen. So I'll go through some of the demographic differences. You can see that we are quite similar. The performance speakers have already mentioned that surgery is the same everywhere, the human body is the same everywhere. So age at surgery, BMI relatively same, the distribution of male, female relatively same. However, if you look down, diabetes, we have a huge epidemic of diabetes, and the government has so-called declared a war against diabetes without much success, unfortunately. So you can see those on insulin, non-insulin meds, and diet, they form 85.7% versus the BQI cohort, 56%. So they are hugely diabetic, and it's a combination of genetics versus diet, probably, and the rich food that everybody is having. So this is some other demographics, and in particular, I wanted to focus on dialysis. You can see the dialysis dependence is really high in our angioplasty population, representing a very sick cohort, 4 times higher than in the US BQI. Hypertension is the same everywhere. However, we have a lot more uncontrolled hypertension than controlled hypertension. So maybe our PCPs not doing such a good job. One thing that we're doing a little bit better, perhaps, is smoking. Our rates of smoking are quite low, perhaps a combination of education and high taxes, likely high taxes. And so we have less smokers. Now, if we look at coronary artery disease, which is also a surrogate for vascular disease, you can see it's relatively similar, except there's more stable angina in our center versus the others. And the rates of CABG and PCI are about the same relative to the 220,000 patient US cohort. So in summary, this is, despite similar age, gender, and BMI distribution, our population cohort have several key differences, notably the high incidence of diabetes. We have 85.7% of the patients are diabetic, and it's a huge problem with us. They also have retinopathy and nephropathy. So with angioplasty, the contrast dye is another problem. We have similar incidence of hypertension, however, more of them are uncontrolled, so that's again not a good thing, representing a sicker group of patients. High percentage of patients on dialysis, so fourfold increase relative to the US cohort of 8.8%. And the only thing is smoking. We have lesser smokers, and at this time we do not have marijuana in the country. I think it still gets you a death sentence. So now when we look at other things, pre-op medications, the primary care doctors do quite a good job of aspirin use with the Compass and the Voyager PAD trials. Use of rivaroxaban is a bit low still, and statins are in the water just like they are in the US. Now when we look at kind of patients we treat, this is again something very different. If I focus on the left-hand side, this is claudication, mild, moderate, severe, and you look, red is the US cohort, blue is the Singapore cohort. So there's a lot more claudication in the US that is treated, versus in Singapore, we treat more of this, tissue loss. So they come in with ulcers, tropical climate. Tropical climates are great for bacteria, and there's a lot of wet gangrene. So there's a lot of tissue loss and ulcers. So that's unfortunately the kind of patients that we're dealing with. If we look at the Wi-Fi score, then again, there is more tissue loss. So blue is Singapore and red is the US. So as we move towards the right, more severe disease in Singapore population, and also foot infection, more severe infections in the Singapore population. Strangely enough, the toe pressures are about the same in the US and in the Singapore cohort, maybe due to calcification of vessels with a combination of diabetes and end-stage renal failure. So the summary for this part will be that most Singapore patients present late for treatment. They somehow think the problem was going to go away, but it doesn't, like everything else. And the majority presents with tissue loss. So there's a lot of infection that are seen in these kind of wounds, and a lot of times they're probably non-salvageable, especially those heel wounds. And 63% present with infection. So the Singapore patients are high risk for amputations rather than other BQI centers. And if we look at the anatomy now, the number of arteries that are treated, the BQI allows only 4 vessels. And we had this problem because in Singapore we sometimes treat more than 4 vessels, so it's the 4 more important vessels. You can see in the US, the majority treat 1 vessel, versus in Singapore, you can see there's a lot of patients having 3 or 4 vessels treated. So they have a combination of above knee and below knee diseases. In terms of types of arteries treated, due to the smoking issue, we have less iliac disease. So in the US, there's a lot more iliac disease, 10-fold increase versus Singapore. So we do a lot of what's called antegrade puncture, where we go downhill instead of uphill. And the preponderance of crampot disease is about the same, but definitely below knee disease, tibial disease is much worse in the Singapore cohort. And these are the small vessels, much like the coronary. So they're small, they're calcified, and they're pain to treat. So these kind of disease patterns are what we treat routinely. So 85% have more than 1 vessel that requires treatment, and many of them, 59%, require treatment below the knee. This is, of course, very different than, when I was a fellow with Andy at the Brigham. Anything below the knee was a bypass automatically. Unfortunately, now we do a lot of angioplasties, even below ankle disease. We don't have a lot of iliac disease in Singapore, as we mentioned. So in terms of lesion characteristics, we have a lot of calcification. You can see on the left side, blue is calcification as you go down the curve, severe calcification more, and then the task classification, which is more C and D, so longer occlusions versus shorter stenoses in the A and B group. And in terms of types of treatments that we render, I think it's quite similar. We don't use the intuitive robot over here. Several endovascular robots have failed, but we use mainly POBA, plain old balloon angioplasty. So mostly angioplasty, no fancy adjuncts, atherectomy, drug-coated balloons, mostly angioplasty, probably for cost reasons, and also because we don't have a separate code for atherectomy like you do have in the US. So this is the most common strategy here. Stenting is very infrequently performed. We like and subscribe to the leave nothing behind concept, so we use more drug-coated balloons than stents. And stents across joints are not very good. So if we look at the lesion characteristics, you can see the occlusion length. This is Singapore, and this is the US. You can see the lengths are shorter in the US versus Singapore. However, surprisingly, the treated lengths are quite similar between the two cohorts. I'm not sure how to explain that. Maybe there's diffuse stenosis that they found. Maybe the balloons are longer. So this is one part that we also do poorly, probably likely a combination of the disease as well as the type of patients, the mentality of the patients, and the lack of transition care facilities. So our length of stay post-op, you can see, is 16 versus the US cohort is 3 with a median of 0. We don't have OBLs pretty much in Singapore. It's a government-funded scheme most of the time, and the patients don't have to pay much when they stay in hospital, so they rather stay in hospital than go home. Because in hospital they get fed, and then when they go home they go find their own food, and then the relatives are all working. So, you know, this is now a changing demographic. People don't have children. The previous speaker spoke about that as well. So they like to stay in the hospital for a really long time until the foot wound heals. So the length of stay is a problem. We are a small country. This is my last slide. We're a small country of 6 million population only, and we're surrounded by water, so they can't go anywhere. So our follow-up rate is very good. Our follow-up rate, I know you can't see, is 93%. So we can find them, even though these are kind of socially disadvantaged and they are, you know, sometimes don't like physicians and they tend to skirt around the healthcare system. We still manage to find 93% of them and do follow-up, especially during COVID was phone follow-up. So thank you very much for your attention.